So what I'm gonna try to do is really tell you my life story, translating targeted treatments for Fragile X syndrome. And this story actually started with a molecule called cyclic AMP. And so I'm gonna kind of tell that from the beginning, and meanwhile intersperse everything else that's gone on in the field that I've worked on. So that's kind of a tall order, and hopefully I'll get through it efficiently. Okay. So what is Fragile X syndrome? Fragile X is a genetic neurodevelopmental disorder, which is associated with some particular physical features, such as large prominent ears, a long face, a large head, prominent forehead and jaw, hyperflexible joints, and a large testes after adolescence. And so as you can see, some patients have a lot of those features and other patients have very little in the way of those features, and you can't really use the physical features for diagnosis at all. What patients do uniformly have is learning problems, particularly the males. Some of the females do escape this because they have milder presentation due to X inactivation. And so the average IQ for males is in the 40 to 50 range. It declines with age during childhood. And this is just that the patients aren't keeping up with the normal rate of development, not that they're regressing. There's a specific cognitive profile, and the most common presentation is speech delay. Patients have a lot of motor coordination and praxis deficits, and behavior problems are quite prominent in Fragile X, with limiting behaviors like anxiety, attention problems, sensory hypersensitivity, hyperactivity, aggression, and perseveration, given here with percents of limiting behaviors in these categories from the Forward Natural History study early on, about 5 years ago. Autism is, depending on what study you look at, present in about 43 to 67% of males with Fragile X syndrome. And there's a list of medical problems that are more common in Fragile X than in the general population, such as seizures, lazy eye or strabismus, frequent otitis media, GE reflux, sleep apnea, and loose stools. Percentages given here from also our natural history study, the initial paper from our natural history study. So how did I get into Fragile X syndrome? Well, it turns out I got into it through a rather side route related to my mentor, Dr. Peter Huttenlocher, who trained me in pediatric neurology. And it turns out he was good friends with Eric Kandel. And Eric Kandel was, heavily into studies of the cyclic AMP signal transduction cascade and the role that it played in synaptic plasticity and learning in aplysia, as well as Drosophila mutants. And there are these Drosophila mutants called dunts, which had learning defects and had high levels of cyclic AMP due to a phospholipidodiesterase mutation. And then other Drosophila mutants called rutabaga, for vegetable, which is, of course, very politically incorrect, that had low cyclic AMP due to an adenylate cyclase mutant, and they had impaired learning. So at one point, Dr. Huttenlocher and Dr. Kandel talked to each other and decided it would be good to try to study deficits of cyclic AMP in humans and look to see if learning disorders with this kind of problem could be identified. And so the obvious thing to study was pseudohypoparathyroidism, which was associated with cognitive problems, and GS protein deficiency, which is the protein that activates adenylate cyclase. And so we tried to find those patients, and we found about 7 of them in Illinois, but we needed an intellectual disability control, and that control turned out to be Fragile X syndrome, because it was the only disease we had enough people with the same diagnosis that we could use. And it turns out that the patients with Fragile X syndrome actually had a bigger deficit of cyclic AMP production, surprisingly to us, than the pseudohypoparathyroid patients were. So then I kind of switched gears and started to study Fragile X syndrome. And I ran, I had an initial assay of patients that I ran. I was studying the cyclic AMP platelets, and I had run an initial group, and it looked like the cyclic AMP was very low in the Fragile X patients. And so I submitted an abstract to Child Neurology Society and then collected a bunch of more samples. And I had to go to the meeting and present, but I also had kind of forgotten that my due date for my second child was at the same time as the meeting. And so I had my second child 5 days before I went to this meeting. I didn't have the samples assayed. I came back, assayed the samples, bought a computer. This was actually so long ago that we didn't have a computer in the house. We bought a computer and printed out the poster at home on our first in-home computer, me and my husband. And then I went and presented this data at Child Neurology Society, which was the first data showing that cyclic AMP in Fragile X syndrome is low relative to control individuals. And these were just dose response curves we had for PGE1, which activates cyclic AMP through a receptor, and forskolin, which directly activates the catalytic subunit of adenylate cyclase. And then we published this paper in 1992 in Annals of Neurology about cyclic AMP and Fragile X syndrome. So then I wanted to do a bigger study. So we did do a bigger study. So we got more samples from patients with Fragile X. We thought maybe this was just from having intellectual disability. So we compared a group of patients. You can tell how old this slide is because we have mental retardation here instead of intellectual disability. And so we did not see this deficit in a few people with autism and a group with mental with intellectual disability. And so this seemed to be a defect specific to Fragile X. We then went on, after moving to Rush, I went on and showed the same thing in fibroblasts and lymphoblastoid cells in a later publication. I proposed to NIH to study this by dissecting various levels of the cyclic AMP signal transduction cascade. NIH thought, why was I studying signal transduction in a chromosome disorder? So they weren't quite ready for this idea. So patients who are participating in my study, though, would come in and said, well, we want a clinic in Chicago for someone to take care of us. And the gene was being discovered right at that time, and there was a lot of attention on Fragile X. So I decided I would start a clinic. And this clinic started at University of Chicago in 1991 and then moved to Rush University in 1992. And so what do we do in clinic? Well, care is supportive in clinic. It was supportive then, it's still supportive now. We got people into early intervention, got them into speech therapy and OT, got them into inclusion in school because they do well with social modeling, talked a lot to schools about the educational curriculum and matching the teaching program to the Fragile X cognitive profile, did social programs, behavior plans, and mainly in clinic, one of the big features of clinic was using behavior medications to try to manage ADHD symptoms, anxiety, and aggression when these got limiting for the patient. And then managing their medical problems to make sure that these did not amplify the disease itself, like managing their otitis media so they didn't have hearing loss, managing sleep apnea, doing eye exams to rule out the strabismus, controlling seizures, orthopedics for foot support if needed, sleep management, and then doing a lot of genetic counseling. We were doing a lot of genetic counseling because the gene is somewhat complicated in terms of how it's inherited through the family, as well as we would discuss reproductive options with families. So we still do all of this today in the Fragile X clinic. And we've seen over 700 patients in the clinic and many outside of the clinic. So what is the genetic problem in Fragile X? Well, FMR1, or Fragile X mental retardation 1, is the gene that's defective in Fragile X. And we now know this is present in about 1 in 4,000 males and females worldwide and is the most common inherited cause of intellectual disability and the most common known genetic cause of autism spectrum disorder. There's a simple DNA test that you can use to diagnose it because it's based on the number of CGGs at the beginning of the gene. And normal genes have 10 to 45 of these CGGs, and then they're transcribed into the RNA because they're located in exon 1, but they're not translated into the Fragile X protein because they're in the 5' untranslated region of the RNA. In the full mutation, Fragile X, the gene expands to over 200 repeats. It gets methylated and shut down, and then no FMR1 RNA and no FMRP are made. Now, there are variants that are mosaic so that some FMRP can sometimes be made. So really, it's a disorder of either absence or reduction of FMRP, and that leads to synaptic deficits and intellectual compromise. So as soon as the gene was discovered, we asked ourselves, well, what's the relationship between FMR1 and cyclic AMP? So we overexpressed cDNAs from FMR1 into neural cells. And this is just showing the cDNA being expressed. And then we could increase the levels of FMRP that way on this Western blot. And the cells that had the transfected FMR1 actually showed higher levels of cyclic AMP, suggesting that there was a relationship. Somehow FMRP was involved in regulating cyclic AMP. And we proposed in that paper that phosphodiesterase inhibitors would be a potential treatment to raise cyclic AMP and treat Fragile X syndrome. But all of the existing phosphodiesterase inhibitors at that time were really too toxic and had big off-target GI symptoms. So we couldn't really use those in a clinical trial at the time. So meanwhile, a lot of work went on in the Fragile X field. And, you know, I was very involved because I had a clinic and a lot of patients with Fragile X and was very interested in doing better in terms of their treatment. So we learned that FMRP exists in an RNA binding complex, and that it sits, this red shows the FMRP at the tips of dendritic spines and regulates activity-dependent dendritic translation through multiple signaling pathways. And that when in the Fragile X mouse, which was created in 1994, what you would see is these long, spindly, immature dendritic spines, as opposed to the more short, mushroomy ones that are the more mature ones. So there were immature, there's morphological immaturity of the dendritic spines, and associated with that, there were abnormalities of synaptic electrophysiology, like exaggerated LTD in the hippocampus, reduced LTP in the cortex, and these abnormalities varied by region and neuron type, but suggested abnormal synaptic plasticity. And so cyclic AMP did continue to be studied as a part of this whole mechanism of FMRP. And in 2006, Bhattacharya confirmed my original work by showing that cyclic AMP production was decreased in the Fragile X mouse brain and in stem cells from that were differentiated to neurons from Fragile X. There was work in the fly that showed that cyclic AMP was reduced in the Fragile X fly. And then the mGluR theory came online about 2002, 2003 maybe, which suggested that regulation of mGluR and other receptors led to activation of protein synthesis, and FMRP regulated this protein synthesis. And when it was absent, a lot of proteins were either excessively produced or in some cases reduced. And so the thinking was somehow that pathway involved cyclic AMP. And so in 2012, it was shown that learning and memory deficits in the absence of FMRP seemed to result from mGluR-mediated inhibition of cyclic AMP signaling in Drosophila. But there still wasn't a phosphodiesterase inhibitor we could use even at that point. And meanwhile, there were other treatments that emerged based on this mechanism. So there were a lot of treatment targets, in fact, that were tested in the animal models. And these include sort of classes of treatments, including mGluR blockers. And these are all different mGluR blockers that were used, where you would block down the excess mGluR signaling through this pathway in the absence of FMRP. Or you could block the actual pathway itself with various things like PI3K blockers or GSK3 beta blockers, a number of things that decreased activity in this pathway. Or you could block down the activity of some of the proteins that are made to excess in the animal models with Fragile X syndrome. Or you could activate AMPA receptors, which were reduced in association with reduced LTP in Fragile X. Or you could interact with the glutamate system to try to reduce glutamate signaling through mGluR receptors with various GABA agents. Or other agents that work on different receptor systems. You could use microRNAs to try to reduce the excess production of some of these proteins. And then there was a mechanism where you could directly block a BK channel that's regulated directly by FMRP. So a lot of different mechanisms. Treatments aimed at everything on this slide, reversed phenotypes in the Fragile X mouse. So you could think that maybe the mouse is relatively easy to correct, but certainly there was a lot of work done. And many of these were used based on mouse work in early human trials. And so these ones that are circled were all in early trials in man. And as time has gone on, some of those agents got to phase 2/3 trials, two of the mGluR blockers and arbaclofen, which is a GABA agent. Many of the agents went through a phase 2 trial, and for one reason or another really didn't move forward. Either there was no path to development or the drug basically didn't work. And then in the green arrows, there are still some things that are in development currently, like metformin and the Neuron drug NNZ-2566 and PDE inhibitors, which are in the process of being evaluated through phase 2 studies. And CBD, which is also being evaluated by Zynerba. So I'm just going to run through the big trials that got to phase 2-3 and what went on with that. Okay, so our baclofen was a drug that rescued multiple phenotypes in the Fragile X mouse, but then turned out to be more difficult in man. This was back in a time when the FDA recommended that we use a primary outcome of the Aberrant Behavior Checklist based on precedent in autism trials for behavior. We even factored that for Fragile X. We had a slightly different factor structure. We ran a phase 2 placebo-controlled study, which did show directional benefit in favor of STX-209 or our baclofen in many different measures. And in fact, a significant difference in this visual analog scale of where we had families rate the 3 worst behaviors of their child with Fragile X. And this I'll talk about a little bit more later. And the ABC Fragile X factored social avoidance scale. So there looked like there was a signal here. We went and ran a phase 3 trial, 2 phase 3 trials, one in the older group, the adolescents and adults, and one in the young kids. The adult adolescent trial did not really show a signal for efficacy. The 5 to 11-year-old trial was stopped early because Seaside was going out of business, and so we only enrolled 159 patients instead of the goal of 200. And in fact, in the highest dose group, parenting stress and ABC irritability were significantly improved, but they weren't the primary outcome. Social avoidance was the primary outcome, and it narrowly missed significance at 0.08. And ABC hyperactivity also looked like it was somewhat improved on the drug. So in this study, the effect size was actually about the same as approved SSRIs used for anxiety. And it looked like from an early group of 30 patients that in the open label extension that maybe over time, the normal drop off in adaptive behavior that you would see on the Vineland, for instance, in things like socialization, communication, and daily living, we weren't seeing that drop off in our baclofen treated patients, but we haven't had the opportunity to further study this. So why did this trial not work? Well, the drug clearly worked in some patients. I mean, we know that I saw 50 patients on this drug, and so I think there's a definite subgroup effect. We used the same inclusion measure as the primary outcome, so families gained their entry and increased their ratings at the beginning, and then of course there was regression to the mean, which resulted in big placebo effects. The outcomes did not pick up all the areas of benefit. The visual analog scale for the specific behaviors in the first study turned out to be much better than parents trying to do a visual analog scale of a general category of behavior, which we had to go to based on FDA guidance. And in some cases, the FDA precedents for the process were a problem, like having fixed doses at doses that were too low and the one behavior. And then there were commercial problems as well. So that did not go forward. Now the mGluR5 blockers, which were back in 2004, 2005, were the great white hope in Fragile X. These blockers have more preclinical data than anything in the neurodevelopmental disability field. The mouse phenotypes, they reduced a huge number of mouse phenotypes, which I'm not going to recite off here, but things ranging from morphological to electrophysiological to biochemical to behavioral to cognitive phenotypes. And shown here is the reversal of the audiogenic seizures and reversal of epileptiform discharges and the normalization of the dendritic spine length on mGluR5 blockers. And so there were over 50 papers from over 20 labs showing pharmacological reversal of about 90% of reported mouse phenotypes by mGluR5 blockers. Huge body of support. And also 6 phenotypes in the Fragile X fly that were reversed. 6 phenotypes reversed by creating a genetic reversal by crossing the FMR1 knockout to mGluR5 heterozygous mutants that had half the mGluR5 receptors. And then there were phenotypes in the Fragile X rat reversed. This led one of the fathers in my Fragile X clinics to say, it's really a great time to be a Fragile X mouse. And in fact, it was, but not so good to be a Fragile X human, because we went into human trials, excuse me, and then we did a very early phase 1B trial where we gave a single dose of phenibom, which is an mGluR5 blocker, and looked at pre-pulse inhibition, which is something you could do after a single dose of drug, and saw improvement over test retest controls. So it looked like we maybe had target engagement. Novartis did a big trial, which really showed no improvement. In fact, the lower is better, and the placebo group was the lowest one here, but you can see during the placebo run-in, they were also the lowest group. So they were just the most suggestible group of patients. And then this is their adolescent trial where the placebo group is in the middle. So no effect on the ABC behavioral scale. And then Roche ran a study where they looked at the ABC and the ADAMS, which is an anxiety scale, and they also did not see significant improvement in those measures. So Roche and Novartis disbanded their programs. We had run a phase 2 sub-study at UC Davis and Rush, where we were able to see a signal in eye tracking on the Novartis AFQ drug, where it looked like the patients with Fragile X on the drug were looking more toward the eyes, at least at the lowest and the highest doses. And they were performing better on this executive function test called the KITAP, where they were doing a go, no go task and showed better, more correct responses and less omissions, as well as some other trends in other subscales of that test. So what went wrong in these trials? How did all that preclinical data on 3 species with 4 different mGluR blocker drugs, genetic and pharmacological correction, not lead to registration? Well, there's probably a list of things. Maybe we had the wrong outcome target. Maybe we really should have been looking at cognition instead of behavior. It looks like we may have had some target engagement based on the study we did with UC Davis. There were big placebo effects. The questionnaires were highly variable and were administered in multiple countries and cultures where you don't even know that people are really filling them out the same. We were at the wrong age to see cognitive change. We should have had younger kids. We may have needed a longer trial to see anything cognitive, and we may have needed a learning intervention. And then there's the possibility the mouse model does not really tell us when we're going to have a drug that's going to work in humans. Here we are still back in clinic, and we have a huge treatment need still. Don Bailey does a survey that shows that the green people are the patients. He surveys all these Fragile X families, and the only people that think their medicines are working well for them are the people with the green here for various kinds of behaviors. And the only thing we're really good at treating is seizures. And a lot of people feel like, oh, our meds are helping somewhat, and some feel like they're not helping at all. Then more recently in 2016 and 17, really, we did this survey, the voice of the patient, and asked families what their biggest concerns were. And if you look over across age, behavior is the biggest concern early on. But by the time people get to be adults, the the intelligence or cognitive problems become big because the patients can't support themselves and they need care. So we then asked families what their drug treatment priority was. And if we just look at the whole group, number 1 is anxiety, and number 2 is learning, and then other behaviors. So really, we have an unmet need for better behavioral treatments and for cognitive treatments. And really, to do this, we probably need to treat the underlying disorder. Protein replacement and gene therapy have so far been difficult, although I think some inroads may be being made on gene therapy. But we recognize we're never going to get anywhere unless we fix our trials and our development process. And one of the key things to recognize is that Fragile X is a complex and variable disorder that's hard to measure the whole disorder. It's difficult to get it into one behavior when the FDA asks you what behavior are you going to treat. We have cognitive issues, behavioral issues, medical issues that are usually manageable, and the physical issues really aren't a big deal. But these cognitive issues and behavioral issues interact, and the cognitive issues result in the learning delays that ultimately impair independent functioning. And of course, sometimes you can have relatively good cognitive function, but then there may be a high amount of behavior that also limits community access and vocational opportunities and housing, and may produce injury to caregivers even and impaired quality of life. And in some cases, this behavior just comes from a severe cognitive impairment and not kind of understanding things, but in other cases, it seems to be sort of primary in a higher functioning patient. So this is a complex thing to sort out. But one thing that was clear is that we didn't really have a handle on how to measure cognition. We weren't even measuring it accurately. And really, all of the studies that were done on IQ before David Hessel developed this method are probably not very accurate, because the lower end of IQ is 40, and many patients with Fragile X fall below 40, so they just have a 40 because it's a floor effect. So what David Hessel did is work out a z-deviation method where we could actually use the Stanford-Binet and what scores the patients got on the individual items to map how the patient was doing, and then it would cover the whole range of IQ. So what we know now is that there's even wider variability than we thought, and this is just a poster that we presented a few years ago using the z-deviation method that shows you the range of IQ. And even in boys with Fragile X, we've got people down from close to 0 up to almost 100. And kind of falling in the middle at an average of 40 to 45 is where the majority of scores land. So now we have a bell curve instead of a curve that looks like this and then just cuts off at 40. So now we can actually figure out who's high functioning and who's low functioning and understand how that impacts patient treatment outcomes. We know it impacts adult outcomes in that the patients on the higher end are the ones who are more likely to get into employment without support. For instance, this is just data on what patients with Fragile X are doing from the Forward database. And so we've got a lot of patients who are still in day programs who don't have employment in the community. And this is impacted heavily by this cognitive curve, so to speak. So we wanted to look at cognitive function with the mGluR5 blockers. We felt that maybe we had been studying the wrong thing with the behaviors. And so we designed a trial and applied to NIH for a grant through the NeuroNext network, where we would study AFQ-056, which is the Novartis mGluR5 blocker, on language learning in young children with Fragile X syndrome. And this got funded. And it's really a trial that is a model for development of a mechanism-based pharmacotherapy in a neurodevelopmental disorder where we can study the effects of the drug on plasticity. And we thought this would be an opportunity to try to really test the mGluR theory in Fragile X. The funding is a complex thing that comes from NIH, the NeuroNext network, and the Novartis investigator-initiated treatment program grant to get the drug. And it addresses many of the problems with prior trials simultaneously, so kind of takes a big chunk of things. Incorporates a young age. It's a longer trial to study learning. We are embedding a language learning intervention, which is a parent-implemented language learning intervention delivered remotely to amplify and focus language learning. We have objective language and cognition measures that we're looking at instead of just parent forms. We have an observational communication measure called the weighted communication scale, which is the primary outcome and is targeted to measure the type of language that we are teaching with the parent, with the learning intervention. Then we have biomarkers to look and see whether there is target engagement, and with ERPI tracking in blood. This is actually the first ever large multi-site trial studying the effects of a targeted drug treatment on learning. So we've been doing this study for some time, 3 years now, and the design is that there's a blinded treatment period. And then patients are randomized, where patients are randomized to drug or placebo. After we stabilize the dose, we implement the language intervention for 6 months, and then our primary outcomes are here, where we're looking at whether the drug amplifies the effects of the language learning intervention more than the placebo does. And then everyone has an open label treatment period where they all get dosing, they all get both the language intervention and the treatment with the drug. And so over time, we can look at how patients do on the language intervention with and without the drug. These are the sites in this trial. This trial enrolled patients from age 32 months to 6 years. They had to be intellectually impaired. They had to speak English because it's a language intervention and we couldn't do it in 2 languages. And they had to be able to have some intentional communication. We did fully enroll this trial a little late, but we did fully enroll the trial, and the goal was 110 patients enrolled to randomize 100, and we did randomize 99. So far, 85 have completed the placebo-controlled period, and we should be finishing up that within the next month. So during this trial, we learned a lot of things and figured out processes for a lot of things that can be used in other trials. And we trained a huge number of different SLPs and psychologists on how to administer different things. And we created processes for synchronizing event-related potentials and EEG, as well as eye tracking between multiple sites. So we had all of these processes for reliability and centralized rating for the weighted communication scale, an intersite reliability process based on review of uploaded sessions to centrally sync all the eye tracking, a phantom that went to all the sites that synchronized our ERP at all the sites. And then we created some templates for Fragile X medical and therapy histories. We anchored CGIs, and we created just forms that would allow a trial to have the kind of documentation that's more appropriate for Fragile X than just like a general trial of anything. We did standardized training of SLPs for the delivery of the parent-mediated language intervention, and we assessed the therapists and the parents on the fidelity of their intervention delivery throughout the trial. And then we created standardized ways of using Skype and internet-based video equipment. And we had all this done, and then COVID hit, and actually our SLPs are running around the country teaching other SLPs how to deliver therapy remotely based on this study. So that's been a benefit that we didn't actually expect to have. So we also needed to really fix the outcome measures that we were using. We were very concerned about being stuck with one behavior and the aberrant behavior checklist. Like I said, we did factor the aberrant behavior checklist to make it factor more appropriately for Fragile X. We also created a lot of different versions of anchored CGIs where there was a more descriptive idea of exactly what we would be rating and how we would be rating it. We've been developing these things like the weighted communication scale that we use in the NeuroNext trial and expressive language sampling, where we videotape a standardized process and then we can rate the patient and how much communication, for instance, they actually have in the communication complexity scale is a scale for nonverbal kids that we can use to measure change in communication function. And then we worked on cognitive tasks. We did a validation study for the KITAP. And then David Hessel we've worked with David Hessel to do extensive work on the NIH Toolbox Cognitive Battery, which is a battery that's administered on an iPad that's a repeatable battery that we could potentially use to measure cognition in trials with intellectual disability and Fragile X. And then David's also created a behavioral app to do real-time sampling of behavior on a day-to-day basis, so you're not subject to recollection bias that families have when they come in and they rate the ABC based on the last day of behavior instead of the last 3 weeks of behavior. So we're working on all these things in the field. We're also working on biomarkers. ERP is a central biomarker of brain function, and you measure it with EEG leads. And we have discovered that in Fragile X patients, we can see similar things to the mouse. Like, for instance, this increase in gamma power is present in both patients and the mouse. And then this decrease in this chirp response, which is a habituation response, is the same in mouse and man. And so these represent biomarkers that could be translated directly from animal models and might be useful for determining target engagement of a drug, for doing early PK/PD studies to determine what drugs to move forward, and for subject selection to find out, well, if you have the abnormality the drug corrects, then we'll put you in the trial. And so we still need to establish clinical correlates with these. We've also been looking at eye tracking, like I mentioned with the AFQ trial, and patients with Fragile X obviously look less at the eyes and more at the mouth and nose. And so we have these patients, and we have all these abnormalities, but we want to map them onto different clinical things, like which abnormality maps onto anxiety, which might map onto focus and concentration, or sensory hypersensitivity, or learning, or social interaction. And so we've been doing some work to do this. I think there's still a lot of work to go to establish this, and then also using iPS-derived neurons to try to find responders and establish cellular clinical correlates. So a lot of work going on, but I want to just move to looking at some of the specific things that we've worked on developing because they're relevant to the trial that we just completed. And so one is the NIH Toolbox Cognitive Battery that we've done validation work, and David Hessel has really spearheaded this entire effort. Where we validated the battery, we adjusted it for intellectual disability to make sure the instructions could be understood, and then asked how many patients with intellectual disability could do this measure and get a score at all, and what's the test-retest reliability, and what's the convergent discriminant ecological validity. And so what we found is that these 4 subtests at the bottom are tests that patients with Fragile X can do over 80% of the time. And for the reading and vocabulary, it's over 90%. And then these ones at the top are a little too hard. They're executive function tests, and often patients can't do them. And so we have a second grant where we're going to try to adjust these so that there's a more doable test while maintaining the correct cognitive construct. The Toolbox Cognitive Composite correlates very nicely with the Z deviation IQ, and we get a nice bell curve with it. And then also the Toolbox does distinguish. We also studied Down syndrome in addition to Fragile X and non-specific intellectual disability, and you can see that Fragile X and Down syndrome have different profiles in the Toolbox battery, so it's able to distinguish cognitive profiles of different conditions. So this, we believe, will address the need for a performance-based cognitive measure for trials. Another thing that has been problematic is that behavior in Fragile X is all over the place. So either you have to hone down and only enroll people with a certain behavior in the trial, which always limits your options and reduces recruitment, or you have to have a way of looking at whatever behavior the person has that's due to their Fragile X. So Seaside did a great job of this in the phase 2 study. So I'm showing their CRF here, where they just said, let's just ask the family what the worst 3 problems they have are and then rate them. And that worked out really well because families knew exactly what they were rating. So then the FDA didn't like that because there were labeling issues and they weren't categories of behaviors. They were all over the place. So Seaside had changed it to parents rating domains based on FDA advice. And that was not good because the parents were like, well, I don't know whether this behavior is anxiety or whether it's aggression, and so a lot of trouble rating domains. Neuron then came up with the idea of the parents would develop their concerns, and then the clinician would map those problems to areas. And we don't know if this solves the FDA issue yet, but it certainly personalizes response and allows categorization of these behaviors and addresses the variability to some extent. So we've carried that concept forward into NeuroNext and into the trial I'm going to talk about. And then ERP is the last outcome measure I'm going to talk about. So this is a measure that can index brain function directly. There are multiple abnormalities that have been described in Fragile X by numerous groups, Craig Erickson, us, and numerous people that went before us. Gamma power, alpha power is abnormal, fituation, chirp, and mismatched negativity, which is a measure response to a novel stimulus. And so the idea is this could be used as a biomarker to translate directly from animals, models to humans. It can be used to determine target engagement. And there's a response, it's known to have a response to minocycline and baclofen that has been worked from Craig Erickson. So we had a study where we were looking at auditory ERPs using the oddball task, and we're interested in this because it relates to language, and so we're using it in our NeuroNext trial. And so this you have a standard sound that you listen to, and then suddenly there's another sound that's different, and the brain processes the oddball sound differently than it processes the standard sounds. And so this is known to be abnormal in Fragile X, but no information on gender and age dependent of the abnormalities and the reproducibility. So we recently did a study where we had 33 patients with Fragile X and 27 controls. and we looked at all the different ERP abnormalities. And so what we did see is those same resting state abnormalities of abnormal gamma power, low alpha power, and reduced reactivity to eye closure that have been noted before, as well as in Fragile X, there's a larger P1, N1, and P2 representing over responsiveness to sound. When you give the oddball, the controls say, hey, this is different, and their brain gives you a bigger response that's delayed because the brain is kind of pausing and saying, what is this? I need to process this. Whereas in Fragile X, you don't get the pause and you don't get the increase in amplitude either. So there's abnormal processing of novel stimuli in people with Fragile X. And we found that females were more similar to controls on this oddball task. And then mismatch negativity comes out of the oddball task. And it's clearly different in Fragile X than the controls, but not significant yet at this number of patients. We had great test-retest reliability for 1 month follow-up, even with only 14 patients in test-retest with ICCs in the 0.65 to 0.96 range. And it turns out we thought that developmental change in these measures would be different in Fragile X from in controls, but it turns out it's almost identical for everything except for P2 amplitude. And so for the most part, Fragile X follows the normal developmental trajectory of these ERP measures, and age is really important for both Fragile X and controls in terms of the expected result that you would get to this. So this clearly has to be a factor in trial design, is which measure you use relative to what age of patient you're looking at, and is valuable information for design. Okay, so here we are in this morass of trials that didn't work and perfection of our outcome measures, when in comes Tetra Discovery Partners, and they are headed by Mark Gurney, who is a person I knew back from University of Chicago back in my old days of studying cyclic AMP. And they had a brain-specific PDE phosphodiesterase inhibitor, a PDE4D inhibitor that had no off-target effects because it doesn't work in the body. It works only centrally. And so they had done studies in mice that showed that, yes, the cyclic AMP is low, but with the drug, the cyclic AMP is normalized. And then they reversed a bunch of behaviors in the mouse, like, for instance, the hyperactivity came down, the social interaction was improved, nesting and marble burying were improved in the knockout mouse. And in fact, there was a carryover effect such that even 14 days after you washed the drug out, you could still see benefit of the drug shown over here and here and here and here. And so this looked promising. They also normalized the spine length. So the spine length is coming down here on the drug, and you have an average shorter spine length. And that's the normalization of the spines because they're normally too long and spindly in Fragile X. And more importantly, PDE4D is all over the brain. So it's expressed broadly, which means you could have a broad effect on the brain if you used a drug that modified it, and is known to be involved in dendritic spine maturation through the cyclic AMP mechanism, which increases BDNF and augments hippocampal long-term potentiation and stabilizes synapses. So this seemed like a good mechanism of action for Fragile X, and Fragile X even has a specific deficit in cyclic AMP that could be targeted with this drug. So we decided to do a phase 2 trial with Tetra, and Fraxa funded it, and so it was a very early phase trial. So we enrolled adult male Fragile X patients who all had the full mutation. We did a crossover design because it helps with recruitment. Everyone gets a chance at the drug, and we actually wanted to investigate the potential carryover effects that were seen in the mouse. But we did pre-specify that if there were carryover effects, the primary analyses would all just be done on the initial group of 15 placebo and 15 drug treated patients. So we randomized, everybody was randomized after screening into placebo or drug. And then after 12 weeks, they crossed over to the opposite arm. And so we were evaluating safety. That was the primary outcome. This is an early phase 2 trial, but also looking at cognitive measures in the KITAP and the toolbox that I told you before that we had worked on validating, as well as a visual analog scale of specific behaviors, the ABC and ADAMS, which are these standard parent reported forms that we had used in the past, and then clinician global assessments. And then for biomarkers, we used our oddball ERP protocol because we thought that might correlate to cognition, which is what this study was really designed to look more at, the behavior and eye tracking. So we enrolled the trial in a year and a half, and we were toward the end, and then COVID hit. And so we had to withstand COVID. And part of that involved, we needed to collect we only had 15 patients in each arm. We needed to collect every study visit. So we did travel to Oklahoma and Miami in the height of COVID last April to do house calls and get those study visits. So the results of this trial came out right at the beginning of October 2020. And that was the 30-year anniversary of when I ran the cyclic AMP assay that I took to Child Neurology Society. And here is the baby who was born when I was running that last assay. And he's now 30, and he has cats, and he is a radiology resident. So a 30-year journey. Okay, so the trial, it turned out we had good randomization, good match between the sequence AB and BA in terms of age, weight, body mass index, Stanford-Binet scores, and the CGI rating. And we did see a carryover effect, which I'll show you. So the primary analyses, as pre-specified, were run on the first 3 months, the first 3-month period of BPN versus placebo. So this, actually somewhat to my surprise, because I wasn't sure we could do this with a drug, is the result of the NIH Toolbox Cognitive Data, where all 4 Toolbox cognitive measures consistently doable by Fragile X patients, which were the ones we were focused on, improved. And in fact, the picture vocabulary and oral reading recognition improved significantly in favor of the drug, and the cognition crystallized composite, which is a composite of these 2 subtests, and mainly reflects language, improved quite significantly. And so this looked like a very nice effect on the age-uncorrected standard scores in the NIH Toolbox. And not only that, so that was a performance-based measure, but we also had this parent measure where we were telling the parents, okay, this is a visual analog scale of what we want you to do is write down what's your biggest problem in 3 areas. We want you to write down the patient's biggest problem in language, the biggest problem in daily function, and the biggest problem in anxiety and irritability categories. So in daily function, parents wrote down things like food preparation, getting ready for work, taking the bus on his own, washing his hair, shaving, bathing, showering, money concepts, doing chores. So these were all things that are very relevant to daily life. And then in the language category, parents told us things like longer sentences, less perseveration, more varied topics, answering the question when asked, better conversation, asking for help, self-talk, and waiting for the right time to talk rather than blurting things out. So these were different things that different parents wrote down, and they wrote down what they thought was the problem with their individual with Fragile X, and then they rated that. And in the drug, and so that turned out strongly in favor of drug for both language and daily functioning, with an average 15-point improvement in both of these scales on a 100-point scale, which was highly significant. So this is a situation where the parents are telling us the patient is better at these tasks we've picked out at the same time that we're seeing them better on a performance-based measure that is presumably not biased. This is what we saw with the carryover effects, in fact. And so initially we see the patients doing better, the patients on drug doing better in these measures. And in fact, this we haven't quite explained, although we do know that sometimes patients with Fragile X do less well as they're in a trial because they don't like to take the tests. But for whatever reason, the patients on placebo seem to go down a little bit in terms of their performance, and there's clearly a separation. But then once they go on drug, they get better in the second part of the study. And the same thing happened really with the parent measures, where the daily functioning didn't do much in the untreated patients, and then it went up in those patients after they went on drug. The same thing for language, and not much separation for behavior, anxiety, irritability. So we had a number of other measures, and many of them actually did show trends in favor of drugs. So the CGI, 26% improved on the BPN with 6.7% on placebo. And that's p.22, but this is not a real sensitive measure, and you would certainly need a bigger trial to see significance there. The KITAP, which again is a computer administered executive battery that might potentially pick up early signal, did show a statistically significant reduction in go-no-go errors and trends in distractibility errors and the mean alertness reaction time. And I just put everything down here that's a p-value of less than 0.25, and I recognize some of these things aren't real, but this is where kind of all the trends were going in the study. And on the ABC, we saw an interesting pattern. There was maybe a little bit of a trend with hyperactivity, but a stronger trend with things like inappropriate speech and stereotypy, which aren't usually the things we're looking for on the ABC. And these are probably more cognitively related. And so we saw some movement on that, and then really not too much on the Adams, although some directional movement, and the Vineland really wasn't sensitive to show change in such a short time. And then in our ERP measures, we showed that there was a reduced N1 amplitude on BPN 1470, this red here, relative to placebo and baseline. And so this was p.06 in only, it wasn't quite 15 patients because not all of them could do the ERP. But so this was an almost significant result on this biomarker. And then in the eye tracking, we saw directional change with increased looking at the eyes and decreased looking at the nose and mouth, such that about 14.7% more time was spent looking at the eyes versus the nose and mouth. But this was obviously not statistically significant in a small group like this. So very interesting findings. And then safety, which was the primary outcome actually, was really, there was an excellent safety profile. We didn't see any of those off-target GI effects. There were sort of like one in each group of a lot of isolated things. And then even these ones with the liver enzymes increased, those were associated with an infection event that probably was the cause of that. And so there was really no significant safety signal here. There were no SAEs due to BPN and no lab or EKG changes. And so then we did an analysis of effect size for the NIH Toolbox crystallized composite and the daily function and language visual analog scales. And these showed very significant p-values and strong Cohen's D's of 0.7 to 0.9. So that suggests large effect sizes. So this is a very strong phase 2 result. This is possibly the strongest phase 2 result I've seen in any study in Fragile X for sure. And I think that hopefully this isn't just a cohort effect, and hopefully we're going to be able to replicate it. We obviously have to be able to show this in a larger phase 3 study, but this is very hopeful. So in conclusion, I just want to say that Fragile X has really been a lifetime disorder for me. It's been the pilot disorder for targeted treatment development in neurodevelopmental disabilities, and the lessons learned can and are informing targeted treatment translation in Fragile X itself and other neurodevelopmental disabilities right now as we speak. And so all the work, I think the TETRA trial is an early indicator, hopefully, that all the work we've put in to develop better outcomes and development strategies is starting to pay off in terms of improved trials, where we can really do a very good early trial and avoid the big waste of a gigantic trial if the drug isn't showing us any signal. We still have lots of work to do at all levels, including the FDA, in order to gain acceptance of some of the measures that really look at the variation in Fragile X and the cognitive issues in Fragile X, as opposed to just some of the tried and true outcome measures like the ABC. I think BPN 14770 is very promising for language, cognition, and function in Fragile X, but we have to, and hopefully it's not, again, a cohort effect, we have to be able to show that in a phase 3 trial, and we will be planning to attempt that, hopefully in the upcoming years. So if in fact we can show that, if in fact we can show the BPN results in a phase 3 trial, then hopefully 30 years of persistence on my part will pay off. And I don't say that because I found the cyclic AMP mechanism in Fragile X first. I say it because I have all these patients with Fragile X who come to my clinic who I want to have better ways of improving their quality of life and improving their outcome across their entire life. And this is just some of my buddies from clinic, my Fragile X buddies from clinic of all ages. And so in terms of acknowledgements, I always show this slide and it just keeps getting more and more people on it. And I always tell people, if you're not on it, it's just because I didn't think of putting you on it, because we've collaborated with like everyone in the Fragile X field. I've trained all these great study coordinators, many of whom have gone on to medical school or fields in developmental disability or genetic counseling or something where they're going to go out and hopefully help the world. We've had funding from NIH and CDC, NeuroNext, the John Merck Fund, National Fragile X Foundation, and FRAXA, as well as numerous industry partners that have been very supportive and helpful in moving us on our journey toward better trials in Fragile X. And I want to call out specifically Abby Outerson, who was the coordinator for this Tetra trial and ran it like clockwork. Claire Mahalik, who's the toolbox coordinator, who is really a guru of toolbox administration. Jeremiah Furman, who does all of our ERP, and Rebecca Yeager, who actually was the travel person who went on the COVID journeys to make sure we would have someone who could administer Toolbox on our COVID travels. David Hessel for developing and for the great collaboration we've had with developing the Toolbox measure. Mark Gurney and Tetra, who've been great to work with, and FRAXA for funding the trial at our site and being, intimately involved in this trend in the process of getting this trial going. And then, of course, all the Fragile X families who are our partners in the journey to develop treatments that will improve quality of life, and that includes participating in all of our natural history studies and outcome measure studies and the trials, and I hope we'll get there for everybody.